In this lecture, we will look at an EKG that demonstrates left anterior fascicular block, which is also referred to as left anterior hemiblock. Here we have the EKG of an asymptomatic 65-year-old female that came into this outpatient clinic. Pause the video and take a few minutes to review it. Start the video when you're ready and we'll go over it together. So this asymptomatic 65-year-old female has an EKG that shows evidence of left anterior fascicular block, which is also sometimes referred to as left anterior hemiblock. Okay, so left anterior fascicular block. Okay, and again, sometimes referred to as left anterior hemiblock. So what is the criteria for left anterior hemiblock? Well, let's go over them. One of the first things you should know is that there's left axis deviation, okay? And it tends to be, so left axis deviation is from -30 to -90 degrees, okay? Because we know normal axis extends from +90 to -30 degrees, all right? And normally you'll see this left anterior fascicular block when the axis is greater than -45 degrees. So the first thing is left anterior hemiblock. Then the second thing we can see is Qr complex or an R wave, and we see this in lead 1. Okay, QR, so a small Q wave and a large R wave, and then or an R wave in lead 1. The third thing is we can see RS complex in the inferior leads, okay? And inferior leads are 2, 3, and AVF, okay? And the main one that you tend to see this in is lead 3, all right? So small R wave, big S wave, okay? So those are the three criteria I want you to know for this left anterior fascicular block. Left axis deviation, typically greater than -45 degrees, a QR, R wave in lead 1, and then this RS complex in the inferior leads, okay, especially in lead 3, okay? So let's take a look at our EKG here. So what is our rhythm, okay? So the first thing we want to look here is we can see that there is evidence of sinus rhythm, okay? So our rhythm here is sinus. And how do we know that? Okay, so we know that because there's evidence of P waves, all right? So if we look down here at lead V1, we can see P waves, okay? And notice that our P waves are coming right before our QRS complexes, okay? So this is a biphasic P wave, and then we have our QRS complex, and we see that throughout, okay? So there's one P wave for every QRS complex. We see positive P waves in the inferior leads. So again, inferior leads, 2, 3, AVF. Notice that here's a P wave, that it's positive, a little hard to see in lead 2, okay? And then in AVF, we see these upright P waves, okay? You can also see them in the lateral leads, all right? Usually V4 through V6. A little hard to make them out in V4 and V5, but in V6 we can see them. They're small, but there, okay? And then in lead AVR, we'll see these negative or inverted P waves. So here's our inverted P waves, these here, okay? So inverted because the impulse is moving away from those leads, all right? So we said P waves before each QRS, there's a 1-to-1 relationship of P waves to QRS complexes. We see upright P waves in the inferior and mostly the lateral leads, okay? And then they're inverted in AVR. Now, how about our heart rate? Well, in order to find our heart rate, we know that the typical EKG strip represents 10 seconds, okay? So if you multiply 10 by 6, you get 60 seconds, and 60 seconds is 1 minute. So if we count the number of QRS complexes going across, we can get an approximation of the rate here. So let's do that. All right, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, okay? So 12 QRS complexes, right? We multiply that by 6, and we get 72 beats per minute, okay? The rate here was actually 68, so it's a pretty close approximate here, okay? So if we have a 68 beats per minute, it's in our normal range of 60 to 100, so this is actually normal sinus rhythm, we call it, okay? So how about our PR intervals? Well, we know that the normal PR intervals is between 120 and 200 milliseconds. So that's 3 to 5 of those small squares or small boxes. Okay, so if you look at lead V1, okay, that gives us a short axis view of the heart and is usually the best one to see. We can see that our PR interval, so remember, the PR interval is from the beginning of the P wave, okay, up until the beginning of our QRS complex. All right, so our PR interval here is actually normal, okay? So the PR interval in this case is actually 188 milliseconds, okay? And that falls within our normal range. So we have no conduction block there. So how about our QRS complex, okay? So on an initial appearance, the QRS duration appears slightly wide, although it's actually less than 120 milliseconds, so it is considered normal. The QRS complex here, our QRS interval, was actually 110 milliseconds. Okay, so remember the QRS interval is from the beginning of the QRS complex to the end of it. All right, and normally it should be less than 120 milliseconds, and we have a normal one here. Now, how about our QT interval, right? The QT interval is from the beginning of the QRS complex, so here, until the end of our T wave. Okay, so this represents our QT interval. Remember, there's also something called the Qtc interval, which is the corrected QT interval that corrects for the heart rate. So our QT interval here, okay, was 440 milliseconds. And the Qtc interval, which corrects for heart rate, was 467 milliseconds, okay? And you can use what's called the Bizet formula to help calculate that, okay? And the Bizet formula, it just means the Qtc interval, which is the Qt interval over the square root of the R to R interval. Now, generally, we have a prolonged Qtc interval when it is greater than 440 milliseconds. Okay, so some people consider if it's longer than 440 milliseconds, it's considered prolonged in both male and female. Okay, now others suggest that it must be greater than 470 milliseconds in female. Okay, so again, you have different variations. Some 440 milliseconds in both male and female, and others say 470 milliseconds in female, and they use 460 milliseconds in males. But our patient here is a female, okay? So as you can see, our QTc interval is 467, which is considered slightly prolonged at least, okay? So we have a slightly prolonged QTc interval, okay? And in such cases, you want to look and check the electrolyte levels, okay? Make sure the potassium level is not low, because sometimes you can have U waves that appear, and you can see sometimes a TU fusion that makes the QT interval seem prolonged, all right? Now let's look at our axis here. Now when we look at axis, we can use our quadrant system, if you recall. Okay, and our quadrant system looks at 4 different quadrants. This is where we put lead 1, the positive end, sits at 0 degrees, okay? Down here, we put AVF, which is the positive end, and that's at positive 90 degrees. This is 180 degrees, and this is negative 90 degrees, okay? Now we know that our normal axis, right, lies in this quadrant. This over here is considered the right axis deviation. This is left axis deviation. And then here is extreme right axis deviation, sometimes referred to as no man's land, okay? Now, normal actually extends into this left axis quadrant, okay? And that's into here, which is negative 30 degrees. If you recall, our criteria for left anterior fascicular block was left axis deviation, but it was between this range, okay? So it's in this region here, okay? So everything from this onward, this is all considered normal, okay? So let's look at our axis here. So we'll take a look at lead 1 here. Notice that our QRS complexes are positive and upright, okay? So we'll be heading towards the positive end of lead 1. And then if we look at lead AVF, okay, this is lead AVF, notice here that it is mostly negative, okay? So we have negative QRS complexes in AVF. That means this is the positive end of AVF. We're heading away from it towards this way, okay? So that puts us in this region. But remember, we have to be over here, Okay, so how do we figure out if we're in that region? Okay, so what you have to do is look at another lead. And what we do is we take a lead that lies right here on negative 30 degrees, and that's lead 2. Okay, excuse me, that is not lead 2. That's the perpendicular line to lead 2, right? That's lead 2 is down here, okay? Lead 2 sits at positive 60 degrees, okay? So that's our lead 2, but the line perpendicular to lead 2 is this one that lies along that negative 30 degrees, okay? So what we have to do is take this line. If it's positive in lead 2, we're going to be on this side. If lead 2 is negative, we'll be on this side, okay? And that will put us in this region. So we take a look at lead 2, which is here. Notice that our complexes here are mostly negative, okay? So that puts us on this side, all right? And in this region, all right? So again, let's just review that. If we draw our complex, their quadrant system, this is lead 1, lead AVF, and then we have lead 2 down here. Okay, that's the positive end of each one. We said that lead 1, right, was positive. We said that lead AVF was negative. Okay, and then we said that the lead 2 was negative, right? And we used this line here, okay, which is perpendicular to lead 2. We said that lead 2 is negative, so it's going to be on this end, all right, and that's why we fall in this region. All right, so that's actually between negative 30 and negative 90 degrees, all right, right in that. The actual axis here was negative 42 degrees, okay? So because of that, we want to start to consider left anterior hemiblock or left anterior fascicular block because we have that true left axis deviation. Now, oftentimes with left anterior hemiblock, the axis tends to be beyond this negative 45 degrees, okay? Here it's only negative 42 degrees, but close enough. So we also have to look at that other criteria, all right? We mentioned the QR complex or the R wave in lead 1, okay? And if we look at lead 1 here, this is lead 1, we have these large R waves that are dominant, okay? So we met the first criteria in the second, right? In the third one, we said in RS complex, in these inferior leads, okay? Especially in lead 3. So we can see that here's our inferior leads, right? We have 2, 3 in AVF. Here's our RS complex and all of them, okay? RS, right? Small R wave, large S wave that we see, okay? So we've met the criteria for all. We have left axis deviation, right? Negative 42 degrees. We have these R waves that we see in lead 1, and then in our inferior leads, we see these RS complexes, okay? So we've met the criteria for this left anterior or fascicular block that we have going on here. Now remember that left anterior fascicle is a thin and organized bundle of fibers off the left bundle branch, right? So we have that his bundle, then we have the left bundle branch, and then we have this thin organized one that's called the left anterior fascicle, okay? And this one is at greater risk than the left posterior fascicle that is more non-organized and has dispersed fibers. Okay, so this one is more commonly injured than the left posterior fascicle. Now, some other things that we can see in this EKG are there's non-specific ST and T wave changes. We can see that in V1 through V4 and also in those inferior leads. So if you look here, notice that we have some ST and T wave changes in here, okay? Seems like slight ST elevation, but those are more repolarization abnormalities. We can see the same thing here in these inferior leads, okay? And some in AVL as well. Now, we also have a normal QRS transition in the precordial leads. Now, what does that mean? Okay, so the precordial leads are V1 through V6, and a normal transition of the QRS complex happens between V3 and V4. So what do we mean by that? So notice in V1, it's mostly negative, okay? Then again, negative in V2, all right? And what we want to have is a negative to positive transition between V3 here and V4. Okay, so look here. We have a mostly negative. Again, mostly negative in V2. So imagine this is V1. We have V2 here. We'll put V3, V4, V5. Okay, and then V6. So you're going to have, eventually it's going to get more positive and we're going to have mostly positive in V4, right, in that transition. Okay, we want it to go from mostly negative in V3 to V4 between this region. All right, so our complexes and our QRSs go from negative to positive normally between V3 and V4. Okay, and we have that going on here. Now, how about our R wave progression? So normally we should have R waves that increase in amplitude in our precordial leads. So V3, V1 through V5, you should see an increase in the R wave. Okay, so here's our V1. This is we can barely see an R wave there. V2, our R wave's getting bigger. Okay, V3, here's our R wave. V4, R waves progressively bigger, in V5 and so forth, okay? And that's as we go around to the left ventricle, we see larger R waves there, okay? So we have a normal QRS transition between leads V3 and V4, and we have normal R wave progression in those precordial leads, okay, up until lead V5. So just to recap the findings here, we said first we have this normal sinus rhythm, okay? We saw why we have sinus rhythm. We saw our rate was 68. All right, so that's normal sinus rhythm. We saw left axis deviation. Okay, the axis was negative 42. Okay, we saw left anterior fascicular block because we met the criteria of left anterior left axis deviation, the R wave that we saw in lead 1, and then we saw this RS complex in those inferior leads. Okay, we saw nonspecific ST and T wave changes. We saw a prolonged Qt interval, and we saw a possible fusion beat that's an aberrant conduction. So that's this one here. Okay, we didn't mention this one, and that's likely an aberrant conduction that we see going on in that beat. Okay, so you can see that this beat here is different than the ones next to it. Okay, notice here, different from the complexes aside from it. Okay, so these are either fusion beats that we're seeing going on here take place, or it could be aberrant conduction, okay, and possibly coming from the right ventricle, but we won't get into that too much here. The main thing I want you to take away is this left anterior fascicular block, and knowing that criteria. Remember, these are the three main things. Left axis deviation, right, that's generally greater than negative 45 degrees. A QR complex or R wave in lead 1. And then these RS complexes in those inferior leads. So that's leads 2, 3, and AVF. Well, that's the end of this lecture. We looked at an EKG that demonstrated left anterior fascicular block, which is also commonly referred to as left anterior hemiblock. I hope you learned something.